a 65-year-old man who came in with a history of poorly controlled hypertension. He develops painful swelling of his right knee following the addition of a new medication commenced by his GP. What's a definitive investigation to confirm his diagnosis? So we're all thinking gout because diuretic, if it's hypertension, it might have been started on a thiazide diuretic, and their side effects can cause increased uric acid, and that can cause gout, which causes painful swelling of the knee, and for that you need to do an aspirate because uric acid levels are not as accurate as getting the aspirate, seeing the crystals. That's more diagnostic because uric acid levels might not be raised. So diagnosis is gout. Usually you have severe joint pain, redness, and swelling. It's usually in the big toe or the metatarsopharyngeal joint of the big toe. The attacks are due to hyperuricemia and deposition of the crystals, the sodium monourate crystals in the joint, and they can be precipitated by trauma, by surgery, by stress, by starvation, by infection, and by the use of diuretics. And the diagnosis may accurately be made by the identification of the urate crystals in tissues and the fluid. So uric acid won't always be elevated, which is why it's important to do an aspirate and check for microscopy to check for the crystals for gout. Okay, next you have a 43-year-old woman with a long history of disabling rheumatoid arthritis who comes to her GP with severe bruising of her upper and lower limbs. She's noted to have central adiposity and her blood pressure is 160/90. Her platelet count and clotting screen are normal. Which of the following medications is the most likely cause of her symptoms? So she has rheumatoid arthritis. Now she has bruising of her upper and lower limbs, and she has central adiposity and her blood pressure is 160. Platelet and clotting screen's fine. So which of the following is the most likely cause of her symptoms? So out of the options that are given, it does sound like steroids would cause this. Steroids that do cause, thinning of the skin, then they're more likely to bruise. They also can gain weight with steroids, and they can get a Cushing-like picture, which she kind of has, the bruising and the central adiposity and the high blood pressure. So I'd go with steroids. Rheumatoid arthritis, they're on steroids as well as DMARDs, and they have lots of side effects, especially if they're on steroids for a long time. So this patient has signs and symptoms consistent with steroid-induced Cushing's disease. This would cause thin skin, capillary fragility that might result in bruising, and then also obviously the central adiposity that she has as well. Okay, next you had a 60-year-old woman who complains of severe pain and stiffness in her right shoulder and swelling in her right hand. She was admitted into hospital 5 weeks previously with an acute anterior MI, which is the most appropriate management for this patient. Okay, so 60-year-old woman, severe pain and stiffness in her right shoulder, swelling in her right hand, admitted into hospital 5 weeks ago with an acute MI. What's the most appropriate management? So people who have like an MI as well, up to 2 to 12 weeks afterwards, they can get shoulder pain and swelling in the right hand. It's fine, all they need to do is physiotherapy, but if that doesn't work, then steroids can be considered. So in this case, that would be the answer, physiotherapy. So shoulder hand syndrome is what it's called. So you can get it anywhere between 2 to 12 weeks after having an MI. It happens with other things as well. With like pleurisy, so it's mentioned here as well, with pleurisy, with painful intrathoracic lesions, cerebrovascular accidents, trauma, rupture of the cervical disc, and cervical arthritis, you can get this shoulder hand syndrome. So it starts anywhere between 2 to 12 weeks after the event, and it's because of the immobility and the fact that it's not being used, and then that's why it becomes swollen and painful. And so early mobilization might, reduce the risk of even developing it before the 2 weeks start. And it involves physiotherapy, and if that doesn't work, the last modality would be steroids. And it's shoulder hand syndrome is thought to be a reflex sympathetic dystrophy and has been noted as a sequel of several conditions like MI, pleurisy, which we spoke about all this. Okay. Next one was a 35-year-old lady who presented to her GP with a 4-month history of dry eyes and dry mouth. Sjogren's. Select the most appropriate diagnosis for this patient. Oh, so it's Sjogren's syndrome. So yeah, dry mouth, dry eyes. You want to think Sjogren's. So which question are you talking about? Why can't it be due to thiazide, pseudogout, and non-steroidals? Let's just go back. 6-year-old, severe pain and stiffness in the right shoulder. She admitted to hospital at 5 weeks previously with an MI. What's the most appropriate management for this patient? Oh, why can't we give her thiazides, ⴤ and steroidal treatment? But we don't give, thiazides with MIs. It doesn't say that she was on thiazide diuretics at all, because there was no mention of the thiazides. That's why we didn't think of gout at all in this case. But if they said that she was on that sort of treatment, because it's painful and it's stiff and it's swollen, those are all that all points towards gout. But if they didn't, like in this case, the first differential that you'd have in your head would be the shoulder hand syndrome thing. But they didn't mention the thiazide diuretics, and you don't usually start all patients on thiazide diuretics after an MI. But nice. Okay, so in this one, you had a 35-year-old lady who presented to her GP with a 4-month history of dry eyes and dry mouth, and we said it's probably Sjögren's syndrome. This lady has primary Sjögren's syndrome. The antibodies that you'd look for are anti-Rho and anti-LA antibodies that are present in 70% patients with this condition, and a positive Schirmer test would confirm defective tear production. Okay, next one, you have a 59-year-old woman who suffers with vertebral fractures. She's had osteoporosis for 5 years, and bone density has failed to improve with bisphosphonates, hormone replacement therapy, calcium, and vitamin D supplements. So next, they gave her strontium, which was discontinued because of diarrhea. And then she continued to have fractures despite being compliant with treatment. The secondary causes of osteoporosis have been excluded. Which of the following is the most appropriate treatment in this case? So since she's had pretty much everything. So she's had the bisphosphonates, she's had the hormone replacements, she's had the calcium, she's had the vitamin D, and she's had the strontium. The next one would be the parathyroid hormone analog, which is according to the NICE guidelines. So if everything else fails, then you'd go to the parathyroid hormone analog, and that's this one, the teriparatide, has parathyroid hormone analog. The teriparatide, or recombinant human parathyroid hormone, is a licensed anabolic treatment given by daily subcutaneous injection. It's appropriate in cases where other therapies failed. So zoledronic acid is a bisphosphonate for osteoporosis that you give yearly. She's already on bisphosphonates and it failed, so then you have to go to the next best option. In that case, it was she had strontium, that didn't work, so then it was the parathyroid hormone analog.